So we'll be talking about bradycardia, and initially I was supposed to talk about the long QT syndrome, but what we found in the last 6 to 8 months is that bradycardia is a feature not only of long QT syndrome, but also of some of the other inherited channelopathies. So this will be new information really for a lot of you. And I didn't discuss my disclosures, but I am funded by the NIH in 2 grants. So what we'll talk about is what are the inherited channelopathies, the importance of the AV relationship in the differential diagnosis of bradycardia, sinus bradycardia, and then our bradycardia toolbox, how to evaluate a fetus with bradycardia, and then I have some cases to go through. So the inherited channelopathies are usually autosomal dominant, and they consist of genetic mutations in the genes that control the opening and closing of the channels in both the cell membrane, as you see here, and the sarcoplasmic reticulum. And these have all really been discovered since the late 1990s, and we know so much more than we used to know. Some of them are including long QT1 and 2, as you can see here, these are in the membrane. And then some of the other mutations, such as those for CPVT, which is another inherited arrhythmia, which causes polymorphic VT, ventricular tachycardia. That's in the sarcoplasmic reticulum, as well as other types of genes. So if you're interested, I suggest this is a really nice review by Peter Schwartz, who really did a lot for the long QT syndrome. So what happens when you have an inherited channelopathy, and specifically in the long QT syndrome, is that the action potential is fine for phase 0, and phase 1, but at phase 2, it prolongs. So repolarization, the time when the heart relaxes, prolongs. And that's seen on the electrocardiogram as a prolonged QT interval, or a corrected QT when you divide it by the heart rate. So you'll have the T wave kind of flatten out, and everything goes much farther away from the QRS duration. So that's the prolonged QT interval. And each of the long QT types, and there's 3 of them, affect different portions of the action potential. And some, such as long QT3, are gain of function, and the others are loss of function in the potassium channels. SCN5A is a sodium channel. And that's all we'll talk about with action potentials, because we all remember those from our earlier training, and it's nice to remember them every once in a while, but not dwell on them. So the long QT syndrome is an inherited channelopathy. It's autosomal dominant. It predisposes about 1 to 1,500 to 2,000 people who are affected by this to ventricular arrhythmia and cardiac arrest. And it, in fact, is the most common cause of sudden death in the young. And it's a lot more common than people really thought. Now, for our purposes, we can only do fetal magnetocardiograms to measure the QT interval at a few places in the United States. So when we look at our echo, what we can measure from the inflow-outflow Doppler is we can measure what's called the isovolumic contraction time. And the relaxation time, I wrote it wrong. And that is the time after, as the aortic valve closes, before the mitral valve opens. And if you divide that by the cycle length, that you get then the normalized isovolumic relaxation time. And that has been found to be prolonged in patients with long QT syndrome. Think of it as a surrogate for repolarization, just as the AV interval is a surrogate for the PR interval on ECG for AV conduction. So when you have a bradycardic fetus, the AV relationship is going to be either 1-to-1 or greater than 1-to-1. When it's 1-to-1, we think of it as sinus bradycardia, even though technically it isn't, right? To have a real sinus bradycardia, it's an EKG finding from multiple leads. The P wave has to be upright in several of the leads. But as long as we can see an E and an A wave followed by a V wave, so the mitral inflow and aortic outflow, and then that AV interval is consistent, then we call that sinus bradycardia. This is an innominate vein tracing and an aorta showing the retrograde flow in the SVC, which occurs during atrial contraction, followed by the ventricular output. And again, we have a one-to-one relationship. When the AV relationship is greater than one-to-one, it's only one of two things, either AV block or blocked atrial bigeminy. And you can tell the difference by looking at the atrial contractions. If you look at this top tracing, the A prime, which is the atrial beat that is not conducted, and the A beat, which is the atrial beat which is conducted, this interval between the two, between the A prime to A and A to A prime, is equal. And that is consistent with AV block. If, on the other hand, you have an A prime to A time difference that's different from the A to A prime, then you're dealing with blocked atrial bigeminy. And blocked atrial bigeminy is just fancy PACs. So this beat that happens here is a premature beat, and that's why the A to A interval is different. So the real deal is the AV block, where the A to A relationship is one-to-one, and the great pretender, which is blocked atrial bigeminy, you can see two A waves that are a little closer together, the conducted and the non-conducted beat. This makes it look easy. It's not, and we've all been mistaken and thought blocked atrial bigeminy was AV block, but you can be fooled. One of the best ways I have found to assess what's going on in the atrium, because this is obviously really important in this differential diagnosis, is to get your beautiful sagittal view of the aortic arch and then drop your M-mode cursor for the atrium. If you think back on when you get a sagittal view, right, you can see that right atrial appendage just beating like crazy, and you can get beautiful and very, very clear images of the atrium. Now, you won't get the ventricle, but if the beat is slow, it's either going to be blocked atrial bigeminy or AV block. And here's an example of blocked atrial bigeminy. Again, the A to A prime. You can see that this time difference is shorter than the A prime to A. So that is the way to differentiate them. And if you're really interested in going into more detail, this is a great paper from Delonia Wiggins and the group up in Madison, which talked about looking at FMCG to differentiate the two, and they have some nice tips and tricks to do that. Very, very nice paper. So we'll talk now a little bit about sinus bradycardia. So I'm sure nobody lies awake and wonders where the definition of sinus bradycardia came from, but this is actually where the obstetrical definition came from. These are the 97th down to the 3rd percentile for gestational age, from 25 weeks to 42 weeks of gestation. And you can see in this 3rd percentile that this rate here never reaches 110. So I think this is why they chose 110 to be the baseline for fetal bradycardia, or the definition of bradycardia. And the 3rd percentile, the 5th percentile, those are all felt to be a low but a normal baseline for a fetus. Well, we took this a little bit farther and tried to look earlier in gestation, and these were the heartbeats of 547 ostensibly normal fetuses. None of them were really checked for any genetic defects. They just came to the clinic and appeared to be normal. And you can see that indeed the heart rate in the 3rd percentile does in fact change and is lowest it reaches its nadir at the end of gestation, and that's pretty well known. But the 110 is clearly well below the 3rd percentile. But what happens if you look at fetuses who we know have long QT syndrome, that is, fetuses who have been genetically proven to have long QT syndrome because of a family history? So if we superimpose these fetuses with a family history who are genetically positive, we see kind of a startling thing. And we see that looking at this baseline of 110, there's only a few heartbeats of long QT positive fetuses that actually get to 110. that the majority of them are less than the third percentile for gestational age. And in fact, when you look at the normals compared to those long QT subjects, you see that there are statistically significant differences at less than 21 weeks, 21 to 30 weeks, and 31 to 40 weeks. But again, these are heart rates that most of you would not give a second thought as to whether or not they were normal. Now, the problem is that the specificity is very low, so this is not a good measurement because it will falsely say that quite a few patients are going to be long QT positive when they're not. Well, we looked a little bit further into this, and we compared genetically proven normal fetuses to genetically proven abnormal fetuses in all 3 long QT types, but we found that that heart rate difference, though it was so discriminating, was really only found in long QT type 1 and long QT type 2. And you see we have a fairly robust series, at least of the long QT ones, but enough to show that in this graph, here are the long QT positive fetuses type 2, here are the long QT positive fetuses of type 1, and then the long QT negative fetuses. And you see that there is definitely a difference, heart rates here on the side, between the negative and the positive fetuses. And in fact, we were able to determine the cut points at these various gestational ages, and below these cut points that was associated with long QT syndrome with a fairly good sensitivity, but a much better specificity, a much more balanced specificity and sensitivity than what we saw with fetal heart rates less than the third percentile for gestational age. So why am I talking about this for a third of the talk, and why is it an obstetrical issue? Why should you care? Well, it provides an opportunity for primary prevention and to improve outcome. We know that if you're not diagnosed with long QT syndrome, you have a definite risk of sudden death, but if you take beta blockers, if you're given beta blockers as a child, they're extremely effective in preventing sudden death. It also allows us to optimize the in utero environment to assure that the mother has normal magnesium calcium levels, normal vitamin D levels and electrolytes, and she's not given any QT prolonging medications. And there are obstetrical QT prolonging medications for sure, including Pitocin. In addition, you can follow these babies a little more closely, follow them for the development of ventricular tachycardia and other rhythms. Follow them for placental insufficiency. We find that the stillbirth rate when the mother has long QT syndrome is significantly higher than in the general population, even if the baby is not effective. There's no premature emergency deliveries for bradycardia, which are the phenotype of the long QT and have nothing to do with fetal distress. Finally, you can deliver at a cardiac center of excellence where the baby can be evaluated right away. And I think the most noteworthy finding is that this is a transient phenomenon, and after birth, the bradycardia goes away and the baby goes out into the world carrying that pathogenic mutation, and nobody knows until they present with a cardiac arrest. Another reason is that even though we think long QT is pretty easy to diagnose, it's not really. It's really good. The EKG is really good at excluding people who don't have long QT. So this is 400, the QT intervals of 441 non-carriers, so long QT negative people. This is acquired long QT, and this is our congenital long QT. And you see that we generally say 470 milliseconds is the cutoff for long QT. Anything above is long QT, anything below is not. But look at all these people here who have QT intervals that are less than what you'd suspect to find in a long QT patient. And babies with channelopathies die. We know that 3 to 10% of SIDS victims have long QT mutations, and 10% of those who die in utero without an apparent cause also harbor these pathogenic mutations. Finally, the fetus can be a proband. The fetus can be the harbinger of long QT syndrome in other family members. As in this case, this was the proband here, and when we went back and tested, we see the mother was the carrier with a QT interval of 427, normal EKG. Two of the stillbirths also were affected, and then two of the little girl's brothers also had long QT syndrome. Again, not very long QTs at all. So we then were interested in saying, well, what else can you get with fetal bradycardia? And this was a study, really two studies, done on fetuses referred with bradycardia. So this is a population, that is not the average population. This is a referral population. So we looked at 85 patients. 28 were looked at by fetal echo alone in Colorado, and 56 were looked at by FMCG in Wisconsin at Dr. Wakai's FMCG laboratory. And what's interesting is that 33% of the total had a negative family history, but were found to be genetically positive for an inherited arrhythmia. And of those with a family history, 32% of the fetuses also were found to harbor that mutation that was found in their parent. Altogether, we had 55 inherited channelopathies. You can see that the majority were long QT syndrome, 37 of them with all different types. But there were 6 other inherited arrhythmia syndromes with mutations in completely other parts of the genes. RYR2, HCN4, those were really the most common. And what's really interesting to me is that 4 of the patients also had channelopathies, but these channels were not found in the heart. So I don't have an explanation for that really at all. So are there clues to the diagnosis of fetal sinus bradycardia? Well, we looked at this also, and we found in long QT syndrome, this was the mean and standard deviation of the heart rate. In RYR2 mutations, which cause catecholaminergic polymorphic ventricular tachycardia, which is a tachycardia which occurs with exercise. And the HCN4 mutations really just cause sinus bradycardia. And these patients probably would have been picked up. Edgar presented one 2 days ago in his case series. We looked at the normalized isovolumic relaxation time, and you see that in long QT and the RYR2, these were prolonged, but in the HCN4 mutations, they were not. Other causes of fetal sinus bradycardia were heterotaxy, which gave an abnormal atrial pacemaker, and anti-Ro antibodies. And again, Edgar talked about both those. Those had the lowest fetal heart rates of all. There were other findings, non-compaction in the HCN4 mutations. The RYR2 patients had premature ventricular contractions, and the long QT patients also could have premature ventricular contractions, different types of AV block, and then torsade de pointe, which is the polymorphic ventricular tachycardia. So just some kind of nice pictures of these different patients. This is a patient with a long QT mutation called a CALM mutation, calmodulin mutation. And you can see that that ventricle doesn't look completely normal. A lot of these patients seem to have some sort of hypertrophy, maybe not non-compaction, but they do seem to have some kind of hypertrophy. This was the patient with the RYR2 variant who had the PVC, which you can see here on the FMCG, but you can notice the irregular rhythm. This patient was an HCN4 variant who just had a very, very, very slow rate. This is the PVC here from this patient here, and that's how that patient presented. Other findings associated with the HCN4 mutation. This is from Dr. Strasburger, who worked with Dr. Wakai up in Madison. And what you can see here is this is the fetal heart rate tracing here. You see there's minimal variability, and then all of a sudden the heart rate shoots up. And these actually are periods of atrial flutter. So these patients can not only have sinus bradycardia, but they can also have other arrhythmias that just sort of come out of the blue and are very unexpected. There are 22 mutations identified on chromosome 15 in the HCN4 mutations, and the other findings include atrial flutter and atrial fibrillation, left ventricular non-compaction, and AV block. These are the postnatal findings, which I'll skip over. So another cause of fetal sinus bradycardia are the SSA anti-Ro antibodies, and you can see nicely that this patient has a sinus bradycardia, but what's noteworthy is the thickening and hypertrophy and brightness, the endocardiofibroelastosis, around the right atrium in this fetus. And that's what gave us the clue that this mother probably had the antibodies, and those were checked. Other medications can cause fetal sinus bradycardia. One of them is methadone, and methadone can also prolong the QT interval. We were fooled a couple times by that, thinking we had a genetic channelopathy, but it was just the methadone, and that went away shortly after the baby was born. And beta blockers can also affect the fetal heart rate. At the ectopic atrial rhythm seen with heterotaxy, Edgar already discussed those. So now we'll turn to the bradycardia toolbox, and I just put this in to remind myself that being a fetal echocardiographer that is doing imaging doesn't mean that you're a fetal cardiologist. And it's really my hope that all of you will approach these fetuses as a fetal cardiologist and not just rely on the echo to make your diagnosis. It's real important to get a history. And as I was told in medical school, that a patient will tell you what's wrong with them if you only know the right questions to ask them. And some of these questions can be the previous heart rates, what they were at various gestational ages. And oftentimes people will say normal, but you really have to be specific. How long ago was the fetal heart rate normal? The gestational age of the arrhythmia, maternal history, obstetrical history, and family history. Then what I like to do is what I call the first glance, and that is the fetus well? Is the fetus with this bradycardia a happy fetus or not? And we can rely on the biophysical profile score and the presence or absence of heart failure. And then what's the general diagnosis? Are we fast? Are we slow? Is there a structural defect too? Is the arrhythmia intermittent or sustained? And then what is the specific diagnosis? So let's go through this for a fetus referred to us with a complex arrhythmia. So the previous fetal heart rates at what gestational age? Well, I was told the fetal heart rates were normal. But if you look and be specific, the highest fetal heart rate was 126 at 12 weeks, and then it was 115 to 120 beats per minute at subsequent visits. Not normal. How long ago was the fetal heart rate normal? 4 weeks. When was the arrhythmia? When did it occur? At 32 weeks. Maternal history, negative. Obstetrical history, pretty unremarkable. No fetal losses. History of arrhythmia in previous pregnancies. Family history, sure, we always asked about a family history of congenital heart disease, but we never ask about the symptoms referable to uninherited arrhythmia, which would be sudden unexplained death, a pacemaker, or a defibrillator. So it was no in all these, as an answer to all these questions. So here's the first glance. Is the fetus well? Well, the fetus was moving around well. Biophysical profile score was 8 out of 8. What about heart failure? What are we seeing here? What's this? Right here, this is the right ventricle. This is the tricuspid valve, and we see this blue flame shooting back here. That's tricuspid insufficiency. So the heart's a little bit big as well. There's some mild cardiomegaly. There's some systolic dysfunction, especially when the heartbeat is beating kind of fast. There's tricuspid insufficiency, and there's a small pericardial effusion. So a little bit of heart failure. So what's the general diagnosis? Well, the four-chamber is normal, and I'll assure you that the rest of the heart was normal too. The arrhythmia is a lot going on. You can't really say if it's intermittent or sustained because it looks like a bunch of arrhythmias. And it's tachycardia and bradycardia. So what's the specific diagnosis? Well, now we turn to our toolbox of that we can find in the fetal echo, which is the M mode and the Doppler. And what we see is during the period of tachycardia, this is the atrium down here, this is the ventricle, and we see that the atrium are beating at a much slower rate than the ventricle. And this is just a picture of the M mode. Then we look at the SVC aortic Doppler, and we see a regular A and a V, but then there's an A here without a V, and then the A returns. So this is AV block. So the fetus is in ventricular tachycardia during the fast rates and AV block during the slow rates. Well, we were very suspicious that this fetus had long QT syndrome, but without the family history, we weren't really sure what we were dealing with. So the mother did agree to an amniocentesis, and we found a de novo pathogenic long QT2 variant in the baby. We also did pharmacogenomic testing to see how the mother and the baby would both respond to the medications. And this is a graph showing what the fetus was doing rhythm-wise, what the maternal vital signs were, and what medications we used, and then what happened to the systolic blood pressure, the heart rate, and the diastolic blood pressure. And we see when we started, the baby was in torsade and second-degree block. We gave propranolol and magnesium, and we immediately converted the baby to sinus rhythm. And we see the subsequent drop in the systolic blood pressure from the propranolol, and also that the heart rate slowly came down. Then we tried to wean her off the magnesium, and we had a long period where she was in second-degree block, but the fetus was still doing all right. And it was finally when we added mixilotine and increased the dose of the magnesium to a level of 1.7 that we had a long period of sinus rhythm. And during that time, the function improved, the effusion went down, and the tricuspid insufficiency improved. So we kept the mom pregnant for 5 weeks. The baby delivered at 37 2/7 weeks. And the little girl was delivered, not a bad size, good APGARs, normal cord gases, and of course had a prolonged QT interval and abnormal T waves, not surprisingly. So I wasn't sure how much time I'd have left, but there are some bradycardia pearls, and that is that repeated measures of sinus bradycardia warrant further pre- and postnatal investigations. It's not just a low baseline anymore. It's something that needs your attention. The diagnosis is not made by echo alone. You have to use all the tools that you can, and you have to have a high index of suspicion. And normal is never the right answer. You need to be very specific. The gestational age at the presentation of the bradycardia can be a clue to the diagnosis. Anterior-mediated AV block or sinus bradycardia usually occurs at 18 to 24 weeks, and it's very, very rarely seen later than that. It can be seen a little bit earlier, but rarely seen later. On the other hand, if you have AV block and a structural cardiac defect, such as congenitally corrected transposition, a beautiful talk that Julia gave earlier today, and heterotaxy, which Edgar's going to give tomorrow, those are two situations where a structural defect can be accompanied by AV block, and those can occur very early. I think we've all seen them as early as 12 to 13 weeks. And not only that, but more than one rhythm problem can be seen in the same fetus. In the presentation, I have a fetus with long QT syndrome that has blocked atrial bigeminy. So that was thought to be second-degree block, but it was in fact blocked atrial bigeminy, and the fetus never had second-degree block. The bigeminy resolved. So this is just a little schematic for the evaluation and management of fetal sinus bradycardia. Everybody needs an echo structure and function to make a diagnosis. Everyone needs a postnatal ECG and postnatal follow-up. For those patients who are vitamin D deficient, and a surprising number of women are, those need to be normalized. If you have elevated maternal anti-Ro antibody titers, you should look on the echo for endocardiofibroelastosis and consider anti-inflammatory treatment with dexamethasone and IVIG. If, on the other hand, you have a suspected inherited arrhythmia syndrome, and the baby is either positive or not negative for a family history, then you should also think about getting a normalized isovolumic relaxation time, as I showed you earlier in the talk. You should look for congenital heart disease, non-compaction, and the presence of other arrhythmias, because these are really the four major causes of sinus bradycardia in the fetus. I just want to take a moment and acknowledge the team at Children's in Colorado. I could not have worked with a finer group of people, and I don't know if you know any of these people, especially the maternal fetal medicine people, but we were both up on the same floor, on the fourth floor, and our offices were right across from each other. Our work rooms were right across from each other. And if you have the opportunity to work really closely with your pediatric cardiologist or with your MFM, I would recommend it highly, because it really advances the field and will result in incredible personal satisfaction for what you're doing for mothers and babies. So thank you so much for listening.